I'm Nigel Edwards. I'm a senior fellow at the King's Fund. I'm chairing the event today. One of the reasons this topic is interesting because across the world we're seeing healthcare systems trying to deal with the problem of growing complexity and multimorbidity, trying to move from models which by volume to those that are trying to achieve value, to keep costs, in other words, to keep costs under control and improve quality and improve, in particular, the longitudinal management of population health. So you're sort of part of a worldwide movement in many ways in which providers are being challenged by payers to take more responsibility for the sort of the risk management of populations rather than just to pay the bills that they're sent for items of service, in which providers are trying to find, and indeed payers are trying to find new ways to engage their patients in self-management, in shared decision-making and care planning, and where we see a shift in that conversation from just being about the narrow biomedical indicators on which we've tended to manage care to a wider definition of the functional and other goals of the patient in terms of their everyday life. It's a different mindset, not just about cure, but much more about care as well. And a big challenge for providers, particularly for hospitals, about the economic model that makes that work. But I think equally, and one that is being neglected a bit in some of the conversations in some parts of the UK that I'm involved in, really neglecting the problem that you really, to make this work, have to rethink primary care in quite fundamental ways in terms of its scale, the extent to which it practices in a standardised, a more standardised way, and the extent to which it is linked and wrapped around with a range of simpler and easier to understand community services, including mental health and social care services, as well as tapping into the resources of the voluntary sector and the wider community, something that we've tended to miss quite a lot in our thinking on this in the NHS. Looking around the world, the lesson of all of this seems to be that this is a process of evolution. There are very few examples of people creating these types of models de novo. So we have evolution rather than intelligent design as our main method of change here, I think, because these models, we're learning how to do them, and there's a degree of experiment and adaptation that's required. Certainly a new set of skills, both from all the way from the clinical front line, the way that various staff roles are defined, getting more blurring between the roles, particularly of AHPs and community nurses. A whole set of skills around data and analytics and how we use the information that we've got available to us. A new way of thinking about anticipatory care, the standardisation of work, and the use of some of those information systems for prompts, reminders, and to help caregivers be more effective. And all of that based on a sort of framework of new and more consistent interprofessional standards. So it's big change, but with big opportunity. And while we know that integration tends to cost before it pays, if I remember most of the research, the overall impact that we're aiming for in terms of improved population health and better patient experience does make this an exciting project. So that's enough from me. That's the longest I'm going to talk for the rest of the day, I promise. We're going to go straight on and we're going to hear a little bit about what's been happening in northwest London. And we've got a double-headed presentation from Thirza Sawtell, who's Director of Strategy and Transformation, the team in northwest London, which is a collaboration of CCGs, and Phil Porter, who's Strategic Director of Adult Social Care in London at the London Borough of Brent. So we'll hand straight over to them. You're very welcome. Good.
Good morning. I refuse to stand next to Phil because he would make me look very short and very wide. So we're going to move over as we hand over between the two of us. I suppose I've been in my role doing a lot of going around the system, looking at integration. And there are a number of things that have been said to me that are true, and I realise they're true, and a number of things where I feel more confident in what we're doing in northwest London. So one of the things that I have learnt in terms of integration is that you can't start it without your own personal story about integration. So I've heard the story from the Director General, and I've heard the story from Ruth Carnell, and I've heard the story from a number of people. I'm not going to tell you my personal story, but I can absolutely guarantee you, for everyone in the room, there will be a personal story of when care works well, and that will be good integrated care, and when care doesn't work well, and that will be when people fall down the gaps between care. So I think that that is a very powerful thing. The second thing that I can say with more confidence than I could is that North West London is ahead of the game in terms of integration. I used to hear that quite a lot and sort of bow my head and think, I hope no one ever comes to look, because it doesn't feel like we're doing that well. But actually having gone out and seen what's happening, I have a renewed confidence that we are doing that well. But it is because we are doing that well that we know that what we're doing is not enough. And that's really what started the North West London programme in terms of moving to whole systems. But the most critical thing that I think has been reinforced for me over the last few weeks and months has been how important it is to start and to end and to continue all the way through with the view of the patient and the carer. And that's what we wanted to do today. So I'm told that this will just work, in that we will now just play you a film of one of the people who've been part of the programme that we've been doing.
10 years ago, I was a very successful television executive, but once an illness gets you, particularly cancer, you have to be very strong. I think people who know me recently would say that the cancer, the second time, really knocked me sideways. I find it very hard coping, particularly also this obvious, what the doctors say is diabetes. I think that integrated care, to me, means that all of these people are talking to one another. They know what you need. If you suddenly have a deterioration or you are suddenly very ill, more people will kick in than used to. They know immediately what I'm allergic to, what pills I'm on, if I'm unconscious and they can't find anything in my handbag, who my GP is, what surgery I've had, and that is developing, that's getting better.
I've got diabetes type 2, and the reason that I've recently had bariatric surgery is to help control my diabetes because it was getting out of control. My GP rang me up with some results and everything from my blood test, and we were discussing them, and he said that my controls weren't very good. He asked my permission to go to a board of diabetic consultants and discuss my case. So yes, they are communicating, and they are communicating, if you like, behind your back, but they do talk to me as well. My GP's been very good that way. It's reassurance for me. I want to know that he knows what his left arm's doing. Them all communicating has given me more confidence, so I'm not so frightened when I go to the doctors now, because I know that they'll talk to me, and if I do have any issues, they're going to listen. Whereas before, I didn't always have that. But I'm a lot happier now, and I am more confident now.
So I really hope for all of the partners of our pioneer North West London integration programme that really sums up why people think that integration is important and why we think that we can improve it. And we have got 31 partners to our programme. Many of you are in the room today, some who aren't in the room today, they're probably stuck on waiting for a tube, but very important in terms of moving forward. We started the programme a few months ago, moving forward from the integration that we had, by developing a shared vision. The shared vision was developed with our lay partners who've been a central part of our programme, and I think that it is a very powerful vision, but it is one of those visions that it is very easy to put down on a piece of paper and not necessarily so easy to put into practice. And what Phil's going to talk about is how we actually move from a vision on a piece of paper to something that is put into practice. We have 3 very strong key principles in terms of integration, which were part of our application and continue to be the bedrock of our integration programme. The first is about people being genuinely empowered to direct their care, really important. The second one is about GPs being at the centre of coordinating and organising people's care. And that's very much what Nigel was talking about in terms of how systems will work around the individual and then around the practice and the networks of practices. And the third one is about how our systems generally will enable and not hinder the provision of integrated care. And it is just amazing how not only do our systems do the opposite of that, but how they seem to be getting more efficient at hindering integration rather than less efficient at doing it. So there is quite a journey to do, and we believe that is one of the strengths of being a pioneer, that we can help address some of those boundaries that are getting in everyone's way. That really says the same in a different type of slide, in that we do need the care to be embedded around the individual, and that is critical. It has to be in the most appropriate setting. A powerful point of the Pioneer programme is that the partners stretch across every setting, and that is really critical, and that we need to have the systems in place to support that. We were told we had to simplify this diagram, and we refused, so you will not be able to read it particularly well. It is absolutely critical to our whole system programme, because what it describes is how we move from a population focus and population health to looking at describing outcomes, to looking at how we move money around to enable care to be delivered differently, to how we stimulate people, both individuals and organisations, to provide that care differently, and what does that mean in terms of providing it differently. How do we put some incentives in for the right behaviour in terms of making sure that we get the outcomes that we want, and how do we then evaluate that? So that sums up the whole systems programme. When you say it quickly like I did, it sounds very light and very superficial. It is probably describing one of the most transformational changes that could be described in terms of the way that health and care is seen anywhere. And we've started that programme by looking at what do we mean by, if we're going to do that, how does that work, through a period of co-design. And that's where I'm going to hand over to Phil, who's going to talk through the co-design and the reality.